In this lecture, we're going to examine specifically blood flow through the heart, specifically here myocardial blood flow, and how this may be related to acute coronary syndromes. And we begin by stating a simple fact here that when we take a look at cardiac cells, so the actual muscle cells that make up the vast majority of the heart, those cells will contract, produce force, and will eject blood from the respective chambers. And those cardiac muscle cells or cardiac myocytes, in order to produce force, requires ATP, which is adenosine triphosphate. This is a molecule inside cells that is considered to be the energy currency of the cell. So this molecule is analogous to money, and that this molecule acting as money must be spent by the cell in order for the cell to produce force. Now, as that ATP is spent, it has to be resynthesized by the same cell. And so cardiac myocytes are highly aerobic, which means that these cells rely a great deal, almost exclusively, on using oxygen to make the ATP that was spent when the cell was contracting. So cardiac myocytes are in a constant state of spending ATP, and for every ATP molecule that is spent to produce force, the cell has to right away make another ATP molecule by combusting fuels inside that cell. And to do that, the cell needs oxygen, molecular O2, to carry out that resynthesis. And that's the foundation for understanding why coronary blood flow is so important to the heart, because without blood flow, the cells don't receive the oxygen molecules that's being transported in that blood. Now, specifically to the heart, under resting conditions, so a person that's not engaged in physical activity, the tissue achieves almost full oxygen extraction from the blood. So all the oxygen molecules that are coursing through the blood, almost all of those oxygen molecules that are, most of those oxygen molecules, over 95% of those, are bound to hemoglobin. The remaining 5% are dissolved in plasma. Almost all of that moves into cardiac tissue. And so at resting levels, the oxygen extraction can range anywhere from 60 to 90 milliliters per minute for every 100 grams of myocardial tissue. Actually, this is the value for blood flow. And with exercise, that blood flow increases considerably. In terms of myocardial oxygen uptake, at rest, it's approximately 8 to 10 milliliters of oxygen per 100 grams of tissue per minute. And this value can increase anywhere from 200 to 300% during intense exercise. And so when we transition from rest to exercise, the heart starts to contract more often. So heart rate will climb from 65 beats per minute on average, or 60 to 70 on average per minute, maybe up to 120 or 150 beats per minute. In healthy young adults, heart rate can climb up to around 200 beats per minute. And the ventricles are contracting harder. All of that extra heart activity will require the cell to spend more ATP, requiring the cell to make ATP at the rate that it's spending, and it's spending it a lot faster, which would require much more blood flow and require a greater uptake of oxygen from the blood into the myocardial cells. Now, we take a look at blood flow through the heart. Flow through the heart occurs during diastole, and diastole is the phase of, we'll talk about the ventricles specifically here, ventricular relaxation. and flow stops during ventricular contraction, that's systole. And the reason that blood flows during diastole and not during the contracted state of the ventricles is that when the myocardium contracts and generates force, it applies mechanical pressure and compresses the blood vessels. Now, this pattern here is opposite to what happens in the systemic circulation or the blood flow through the rest of the body. And so when the ventricles contract during systole, that will increase blood flow into the systemic circulation, but will stop blood flow during the period of contraction throughout the actual myocardial tissue. And then when the ventricles mechanically relax, blood does not leave the ventricles, and we don't have blood flow through the systemic circulation, but we have blood flow through the actual myocardial tissue. Now, what does it take to occlude blood flow through an artery under resting conditions? At least 75% of that artery must be blocked by plaque. And so when we see that we have this much, that will provide a serious impediment to blood flow through the artery, and if that blood has to reach myocardial tissue, that will pose a unique problem. Another condition that is somewhat related to this is a stenotic artery. And so a stenotic artery is one that has a reduced size of the opening. And this could be caused from a couple of different things. One factor that would reduce the opening of an artery, of course, is plaque, particularly if there is a lot of plaque that is accumulated. And once again here, we come back to the number 75% under resting conditions that would cause that occlusion. But it can also occur with what's called vasospasm. Recall that arteries are surrounded by smooth muscle, and can that smooth muscle contract contract to a point where it would close and collapse the artery and prevent blood flow? And it certainly can. And there are a number of different factors that can cause that vasospasm, that continual contraction of the smooth muscle that would reduce blood flow. And that includes endothelial dysfunction. So the layer of cells on the inner part of the blood vessel, if those cells are not functioning correctly, which is what dysfunction implies, then the molecules that are produced by the endothelial cells would not cause that smooth muscle to relax. Increased activation of the sympathetic nervous system is one of the effects of sympathetic activation is to trigger smooth muscle contraction, as does circulating epinephrine. And the circulating epinephrine through the cardiovascular system comes by way of release from the adrenal gland. And so either direct activation of the smooth muscle from the sympathetic nervous system or indirectly through the secretion of epinephrine from the adrenal gland. The images here on the right-hand side goes back to some of our first points here, where the blue represents myocardial tissue. So these are the muscle cells of a portion of the ventricle, and in order to provide those cells with the oxygen and the nutrients that those cells need, we have a coronary artery embedded deep in that tissue. And we can see here nice relaxed myocardial tissue, and with that nice relaxed myocardial tissue, we see that the coronary artery is fully dilated and blood can flow through. Now we have here cardiac systole, and so now we have the myocardial tissue occupying less space because those cells have contracted. And that effect will apply compression to the artery, which would compress that artery, and occluding blood flow through this vessel. And so once again here, one last point that we made earlier is that blood flow through the heart occurs during ventricular diastole, which is the relaxation part where the tissue is nice and relaxed, and blood flow stops when the ventricles are contracted, because those ventricles will compress the blood vessel coursing through the arteries coursing through that tissue. Now, myocardial ischemia is a particular problem here, which refers to inadequate blood flow. So the term ischemia refers to inadequate blood flow, which is a problem because without blood, the tissues would receive inadequate support. And so what are those tissues? We're talking about the heart tissue itself, the lungs, and the rest of the body. And so this poses the next question is what kind of support is needed? Well, what's being delivered through blood is molecular oxygen that was originally obtained from the external environment, nutrients from our diet, as well as hormones that get secreted from a range of different endocrine glands. And it's not just the delivery of molecules that's necessary to maintain the health of tissues. During the course of metabolism of those tissues will produce metabolic end products which would otherwise be toxic to those cells. So the blood, as it's coursing through the tissue, as it's delivering oxygen, nutrients, and hormones, which moves out of blood into tissues, we have the end products of metabolism moving in the opposite direction into the blood for removal. Now, as it relates to blood flow through the heart, there are some abnormalities. And one of the overall concern here with any abnormalities in myocardial ischemia is a decrease in what's called the left ventricle ejection fraction. And that's the amount of blood, of the total amount of blood in the left ventricle that eventually gets pushed out of the left ventricle with ventricular contraction. That's important because that blood that's leaving the left ventricle is serving the needs for the whole body in terms of oxygen and nutrient delivery. And so what the pathway here, or the factors that contribute to a decrease in that amount of blood leaving the left ventricle, one factor here is left ventricle stiffening. And so if we have the tissue of the ventricle that's very, very stiff, it can't expand very easily. And that's a problem because we want the ventricle to expand to accommodate blood flow during what's called diastolic filling. So diastolic filling is the movement of oxygenated blood from the left atrium into the left ventricle, but the left ventricle has to be relaxed enough in order to expand. A stiff left ventricle will reduce the amount of diastolic filling that can occur. Less diastolic filling means that there's less blood to deliver to the body. Abnormal contraction patterns. There is a very reliable and consistent pattern in which the cells of the left ventricle contracts in a very unique sequence. But oftentimes, those contraction patterns can be abnormal. And if they're abnormal, it will produce a rather inefficient contraction, decreasing what's called systolic emptying. And so that refers to the amount of blood leaving the ventricle when it's contracting. ECG abnormalities. So the ECG, as something as was reviewed on a previous video, is the electrocardiogram. And the electrocardiogram is the electrical pattern that excites the different parts of the heart. And we'll address that in part 2 in a subsequent video as well. But any abnormality in that normal pathway of electricity through the heart will change the pattern in which the heart will produce force. Uniquely, altered repolarization. So repolarization refers to the electrical phase in which the heart chambers are deactivated. Depolarization, depolarization, is the phase in which the chambers are activated. Repolarization is the next electrical phase following depolarization that will reset the electrical state of the heart back to a resting condition. And angina pectoris is a condition that is chest pain resulting from myocardial ischemia. And it's transient in nature in many cases. Silent angina pectoris is something where the person would not necessarily feel any type of discomfort, but that's problematic because the person can still experience myocardial ischemia. But in the case of angina pectoris, the the discomfort, the pain would radiate to different parts of the body, and so it would be substernal or beneath the sternum, and radiate into the jaw, the neck, and the arms. And this is more of a heaviness type pressure, high pressure type of feeling, and can come with dyspnea. And so dyspnea is an alteration in breathing patterns. And this can often occur because of high blood pressure of the vessels, specifically through the lungs, so through the pulmonary circulation. If the pressure is very high, that's going to interfere with blood flow, that would interfere with breathing patterns. There are triggers for angina development, and that relates to different types of angina. The first one here is what we call typical angina. Typical angina is one where a person would actually experience symptoms of heaviness, squeezing, and pressure that is substernal and may radiate into the neck and jaw and possibly our region. And this can come on through physical exertion or emotional or psychological stress. Recall, emotional and psychological stress will generate a fight or flight response, which is activation of the sympathetic nervous system. And when the sympathetic nervous system is activated, it triggers overall vasoconstriction and vasoconstriction through smooth muscle contraction. And when that happens, that can contribute to myocardial ischemia. Large acute changes in temperature, and this is environmental temperatures. And so if a person submerges themselves in very cold water or jumps into very warm water, that can cause an overall response in the body that could trigger myocardial ischemia, as can various medications. And typical angina is characterized by relief of the symptoms, either through simple rest, so the person, if they are physically exerting themselves to stop physical activity, or placing a nitroglycerin, a very small nitroglycerin tablet underneath the tongue, sublingual, and that will cause a very rapid breakdown and absorption of nitroglycerin, which serves as a potent smooth muscle relaxer. Atypical angina is, as the term suggests, atypical in terms of the symptoms. So the symptoms with typical relate to a feeling of heaviness or squeezing or pressure in those indicated areas of the body. Atypical is a little bit different here. The pain that's often, or the symptoms that are often reported, include more of a sharp or stabbing type of pain or a tingling pain. And so the factors related to atypical angina, for the most part, are the same as typical, with the exception of these very unique symptoms and atypical tends not to be physical exertion related as typical angina is. Stable angina is referring to the development of the symptoms that is predictable. And so a person that engages in physical activity can expect can expect these symptoms to come on, not just in terms of the onset, but the magnitude or the severity and the relief. And that reporting of the symptoms will help to drive the treatment protocol for the healthcare team of that patient. Unstable angina is the term unstable angina is typically used when there is a new onset of typical angina, and with each episode, the intensity of the symptoms, the duration of the symptoms increase, and the episodes increase in terms of frequency, or is typically experienced under resting condition. And unstable angina does carry some unique risks. The most obvious risk here is an acute myocardial infarction. And the most common cause of unstable angina, which may lead to an acute heart attack or myocardial infarction, is atherosclerotic plaque. And the problematic issue with atherosclerotic plaque is that this is tissue that is more brittle than it is pliable. And brittle tissue doesn't quite bend into a new shape. It cracks or it breaks. And so the problem with plaque is that it is subject to cracking and rupture. It is subject to erosion because this plaque, which is formed on the interior of blood vessels, is constantly eroded by blood that is constantly flowing over this material. And this can occur with or without thrombus formation. Thrombus formation refers to the overgrowth of a blood clot, for the most part, or some other element in the blood that would obscure the flow or obstruct the flow of blood through a vessel. Or it can occur with vasoconstriction. And so these possibilities can develop into an acute coronary syndrome, and this can occur without atherosclerotic plaque. So this can occur through vasospasm, through other types of microvascular diseases, and as well as myocarditis, so an inflammation of the actual myocardial tissue can obscure and obstruct the flow of blood through that tissue. And so that does become problematic because if the actual muscle cells become inflamed, they could apply pressure to those vessels and reduce the size of the vessels. That would see a reduction in blood flow. In terms of the effective duration, the occlusion of blood or myocardial ischemia is considered to be transient if it's less than 10 minutes. And the reason this would relieve within 10 minutes, and that would occur because of something called thrombolysis. And so if it is caused by a thrombus, perhaps a dislodged blood clot that got wedged into a small arteriole, that blood clot may have ruptured and dissolved, and that blood would then be allowed to flow through the vessel. That would result in a decrease in those symptoms. Or the smooth muscle would be triggered to vasorelax, and this can sometimes occur without any sort of medicinal intervention. If the duration of the angina starts to approach the 60-minute duration, then it's highly likely that the person is experiencing an acute myocardial infarction. And the myocardial infarction or the heart attack is of concern because comes with this is the physiological outcome of blood vessel occlusion. And the occlusion will cause ischemia, which is a reduction in the blood flow through the coronary arteries, supplying the tissues with the oxygen and the nutrients those tissues need to survive. Now, without that blood flow, that would cause something called necrosis, which is tissue death. And the problem with the cardiac myocytes is that when those cells are no longer functional, those cells die. They don't have it doesn't have the ability to regenerate. So that certainly is a problem here with these occluded blood vessels. And so the necrosis is just, as I indicated, refers to the death of the cardiac myocytes. Now, when cardiac myocytes are no longer viable, these are cells that will start to break and dissolve. And one of the first elements of the cell that fractures is the membrane of the cell. So with cell rupture, a protein involved in cell contraction called cardiac troponin, or abbreviated as CTN, this is a protein embedded inside these cardiac muscle cells that if this protein is detected in the cardiovascular system, so with a blood test, and they can be detected fairly quickly, that is often that is used as an indicator that the cardiac myocytes have started to release this protein in the blood. And the only way for that to happen is if the cardiac muscle cells are no longer functional and have started to die off, and the membranes have ruptured. So on the right-hand side here, in this drawing here, on the left-hand side, here we see the right portion of the heart, the atrium, the right ventricle. Here we see nice red tissue indicating healthy tissue, but here we see tissue that is much more pale. This is typical of cardiac tissue that has experienced a myocardial infarction. So these blood vessels have been obstructed somehow in terms of blood flow, and without receiving oxygen and nutrients, these cells are no longer viable and have died. And in this illustration, we're just going to highlight the two drawings here on the right-hand side. So atherosclerosis is the actual physical obstruction of blood flow through the development of what we call atherosclerotic plaque. And once again here, this is a painless disease. A person doesn't experience pain due to plaque, but this develops over the course of a long period of time. In terms of vasospasm in this artery here, we don't see any plaque formed, but we see the smooth muscle at this location hypercontracted. And if this stays hypercontracted for a prolonged period of time, that will reduce enough blood flow to deprive the myocardial tissue with a sufficient amount of oxygen that would contribute to the death of those cells. So this ends our second video on part 2 of acute coronary syndromes.